this episode of the Diary of a Sickle Cell Prodigy series, we are joined by healthcare influencer, sickle cell advocate, and family nurse practitioner, Maya Bloomberg. Maya is a registered nurse at the University of Miami Miller School of Medicine who specializes in non-malignant hematology.
My name's Maya Bloomberg. I'm a hematology nurse practitioner, and I've been in my current role for 7.5 years almost now. I specialize in non-malignant hematology, so this includes sickle cell, bleeding disorders, clotting disorders. And before becoming a nurse practitioner, I was a bedside nurse on a medical surgical telemetry unit. So I was exposed to a lot of different medical conditions, and I was also exposed to different attitudes and care towards patients. I would say once I became a nurse practitioner is when I really realized a lot of the disparities and racial disparities for sickle cell specifically. And during COVID is what brought me to bring my voice and use my expertise to kind of help bridge racial and health disparities among sickle cell patients and multiple people. When I was a bedside nurse, I cared for countless sickle cell patients, inpatients. So when you're in the hospital, you're seeing the worst of somebody and you're really only focusing on the pain and the anemia. It wasn't until I was an outpatient nurse practitioner, I still do inpatient, but primarily outpatient, where I was seeing a lot of the similar patients that I was taking care of in the hospital, now outside of the hospital, and learning so much more of sickle cell and realizing sickle cell is more than just pain. It's more than just anemia. It's something that encompasses the entire body. It's associated with a ton of complications, premature mortality or death, that I had that first eye-opening experience, like, wow, there's so much more to sickle cell. And I was the person who was always assigned sickle cell patients in the hospital because we know that there's a notorious negative attitude towards sickle cell. And it's unfortunate that there's the misconception that sickle cell patients are portrayed and painted as the difficult patients, when in reality, they're in pain, they need help, they want to be listened to. And as you mentioned, they're in a healthcare system that is set up to fail them and really not help them. So once I became a nurse practitioner and really saw what these health and racial disparities were, and seeing my patients affected significantly. And these are patients who might be hospitalized once every 2 years, being categorized as drug seeking or frequent flyers. And it was just very upsetting. So I felt like I needed to start advocating for them. The physician I work with, Dr. Harrington, he is this program director of our sickle cell program. And he's the one who is very passionate and ignited my passion in sickle cell. So the two of us, we make an awesome dream team. But as I mentioned, during COVID, an article had come out which was showing how life expectancy across the board had decreased, which is no surprise. But when you broke it down by race, there was a huge racial component where it was only decreasing 1 year for Caucasians and almost 3 years for Black African Americans. And it's not because more melanin in your skin increases your risk for complications, but that's what kind of triggered me. Like, what can I do to help bridge this disparity? And we know hematology can be very complex. And I'm a nerd at heart. I was valedictorian and Club Richter VIP, which was the library in my sorority. But I feel like I have a knack for simplifying things, because when you understand the why behind why your provider is telling you to do something, you're much more likely to do that said thing. And with sickle cell, we know there's a shortage. I was going to say a national shortage, but really a worldwide shortage in sickle cell specialists. So many patients are just getting connected with a hematologist oncologist who primarily takes care of oncology or cancer patients, and are really probably only focusing on the pain and anemia. So I wanted to use my page for those patients as well, who might not be connected with the best specialist, but maybe if I gave them information, it could then trigger some more meaningful conversations, because patients need to realize you are in control of your health. Yes, you're living in a world where the healthcare system is really set up to fail you, but that's not a reason for you not to take your medications, to drink your fluids, to avoid your triggers. There's a lot that you can do. So I'm trying to empower patients to learn how you can really self-advocate and live a longer life. So when I first became a nurse practitioner, after being in the hospital for so many years, it was very obvious the doctors who are passionate and join the field because they want to take care of patients. And you can tell the ones that are doing it for a paycheck and view patients as numbers. So when I became an NP and was trying to figure out where I should specialize in, I didn't say, yes, I want to be a hematology nurse practitioner and specialize in sickle cell. I was just focused on the provider that I was getting matched with. And I turned on 2 jobs because in my heart, I just knew it wasn't going to work right for me, even though I wanted to get a job before I took my board certification. So when I met Dr. Harrington, it was almost like a reverse interview, but we were going down the list and he was one by one telling me each patient and a history about them. And I knew that not all doctors are like this. This is somebody really special. And when it comes to being a nurse practitioner, there's a huge scope, and some nurse practitioners can be viewed more as an assistant or a scribe, while others can practice more independently. So the dynamic, the 2 of us clicked immediately. We don't take ourselves too seriously. We're both very smart. We know how to be professional, but at the same time, we like to have fun. And I think just that connection and rapport with our patients is appreciated. And we just have the same viewpoints and we see the disparities. We also specialize in hemophilia. We work at a hemophilia treatment center. And when you look at hemophilia, it affects around 25,000 people in the United States. Look at sickle cell, it affects around 100,000 people in the United States. In the past 5 years, we now have 4 treatments for sickle cell. But when you look at hemophilia, there's dozens of hemophilia treatments. There's so much more funding. So from day 1 of my job, the disparities just between 2 rare diagnoses was very amplified. And it's just been heightened with time and time. So we have a wonderful dynamic. He allows me to work very independently, but at the same time, we work so well together and our viewpoints are very similar. So he's my mentor. He's the one who ignited this passion in sickle cell and just bleeding disorders and everything that I specialize in. But he is wonderful in the sense that he truly cares about his patients, most importantly. When it comes to nursing, I learned a lot of things that I like to share for any new nurse. And one thing that I share is no death gets any easier. And this is just one of my messages that I try to communicate when advocating and spreading awareness to sickle cell is how fragile this condition is. And you can be totally fine 1 second and the next have just a catastrophic event that ends your life. And it doesn't get easier. Every time it's very hard, even if it's an older patient who has a lot of complications. I formed connections with these people. I went into nursing. I mean, I always knew I wanted to be a nurse from early on. I've always loved helping people. My mom raised me where we treated the janitor the same way that I would treat the CEO of a company. So, I mean, my heart is always just there to help somebody. So when it comes to these complications, it's very difficult when it's just one back to back to back. I mean, I've come home crying before to my husband and it's just, it weighs on you heavy. And I think when you couple that with just the misunderstanding and the judgment that this disorder carries, it's even harder because if people truly understood what this disease entailed, I would hope that there would be more compassion. That being said, I try not to focus so much on that because I don't want my patients to live in fear. Yes, it can happen, but again, we can do a lot of things to help control some factors. Some factors you cannot prevent, other factors you can. So staying on top of your doctor's appointments, making sure you're staying on top of your lab appointments, because we know this can cause complications, but we also have ways to screen for them. And when you're screening, you're trying to pick it up before it's becoming a complication and becoming a problem. So there's a lot of ways that you can use the information to just advocate for your health. So anybody listening to this, I'm not trying to scare you or depress you about you having a crisis and this being your last one, because in reality, you are in a lot of control of your health. It's just knowing what you can do, when to contact the provider, so these issues can be picked up a little bit earlier. It's one thing that it's very true. So I always say I will not give medical advice. But that being said, if somebody asks me a question, I'll always give a disclaimer. I can't give medical advice. You need to speak to your provider. But if you were my patient, maybe consider doing X, Y, and Z, because again, not all providers are comfortable or really understand how things can interplay. So I feel like I'm helping just provide information, but I can't provide medical advice. That's where the big liability is. When it comes to just my personality in general, I love learning. I'm such a nerd, and my anxiety, I like feel my anxiety by knowledge, and knowledge is power at the end of the day. And when I am putting information out there, this is going to be out for the rest of the world, that I need to make sure everything I'm saying is by the book and is factual. So even though I have these conversations and I could do it in my sleep with my patients, I want to make sure that 100% it is factual. So a lot of times when I'm making my posts, I will look at evidence-based research and just make sure that the statistics and the numbers and everything that I'm saying is in fact correct. I do cite the sources as well, so people can go back and look at that. But I think the key is these evidence-based articles are very medically rich and can be very overloading and overwhelming. So I try to pull the pieces of information that are the impactful pieces that I think are going to bring that home message of why something is important. But it is a liability risk. And I feel like I just put the disclaimer out there that you need to speak to your provider at the end of the day. I cannot give medical advice, especially without seeing you and feeling you and looking at your lab results and putting all of this on paper. But I do try to provide some guidance because I know that there really aren't a lot of providers out there that can help patients. Especially, it's pretty cool that I have such a large following in Africa and Nigeria and Lagos, that the fact that we've been reaching all over the world, it's been eye-opening just seeing access to treatments. I mean, we've had Advocacy or crizanlizumab approved by the FDA since November of 2019. And last year, all of a sudden, there's this new treatment that's been approved in the UK. And I'm thinking, how's there a new treatment that I haven't heard of? And it ended up being this one. So it shows just the lag, and it makes you question, why was there such a delay? And even in Nigeria, with hydroxyurea use and just the access to that, there's a lot of disparities that I feel like if I'm able to just guide somebody and make them realize that there are certain things that they can incorporate in their life or decisions to make, or go to their doctor and ask to have something checked to ultimately help their health in the altruistic sense, I feel like that's kind of fulfilling my purpose. But it's important for everyone to understand that ultimately they need to speak to their provider who knows their history. I am not your medical provider. I'm just feeding you some seeds that might be helpful for your health. If you said this to me a couple years ago, I would totally agree. However, now I must give the pharma companies some credit because I do think they are incorporating more patients. I participate in advisory boards, and I've always said that the social issues in sickle cell is what really needs to have the attention, and we're only going to fully understand by involving patients in that. So I mentioned there's a lot of research and new products in the pipeline that are in clinical trials currently, and a lot of these manufacturers have hired patients. So I'm always giving patients so many kudos because I have a lot of very successful sickle cell patients who have become PharmDs, have become doctors, have become lawyers, etc. And I've seen a lot of pharmacists with sickle cell or people with connections. So I do think that they are incorporating more patients. I've had companies ask for patients specifically to be involved in advisory boards, and I can give some patients information in order for them to be included so their voice can be heard. So I think there is, but with everything we're seeing, it's just a very slow effect. But that's why in the past 5 years, there definitely has been so much more interest and an improvement, and we're seeing it before our eyes. But I hope there's a lot of advocates that I see on social media who have been connected with GBT, for example, which came out with Oxalitor, Oxbryta. So I think they are incorporating more patients and getting their insights and experiences to help frame that. But you are correct. We need to include the patients to really amplify what the issue is, because medication isn't going to outweigh a stressful living situation that they can't address, or mental health issues, etc. So it's slowly coming, it's slowly improving, but we're not totally there just yet. We have research that shows that compared to other conditions, sickle cell patients have longer ER wait times. They have longer time until they receive their first dose of pain medication. And oftentimes they receive inadequate doses of medication. When able, I always have my patients come to my hospital if they can, so that way we can call the ER triage and let them know that sickle cell patient is coming in and kind of explain what needs to be done to prevent delays. We also have sickle cell plans specifically for the emergency room. So if a patient comes in with sickle cell, you pick the emergency room sickle cell plan and you have everything pre-populated that you click. That being said, does the ER doctor always click what we want? No, because when it comes to physicians, when it comes to pharmacists and people with medical license, at the end of the day, it is their license. And if they don't feel comfortable prescribing something, they have the right not to prescribe and not to order it. Even if I call or if Dr. Harrington calls and says this is what they receive, it doesn't mean that it's going to be carried out. When you get admitted to an outside hospital, you can try to have your primary hematologist call and let them know what your complications and what your treatment regimen is at home. Because again, there's such a misunderstanding and a judgment when it comes to sickle cell patients that a lot of, I don't want to say a lot, but there are a group of patients that their sickle cell management is just going to the hospital anytime they have a crisis. And that unfortunately is who these ER providers are clumping together when they see a sickle cell patient. So sometimes when a provider in the ER knows, hey, this person is followed by Maya and Dr. Harrington outpatient, they have X, Y, and Z complications, that might change the perception and make that provider know, yes, this person is taking care of themselves and trying to avoid the ER. They just had some trigger and needs to receive care. Again, not always going to happen, but it might help. And also you can even consider getting a letter, a diagnosis letter from your provider that outlines where you're followed, what your complications are, what your treatments are, your emergency care plan, like what you should receive for pain management. So again, it confirms that you are taking the steps and being followed outpatient to prevent emergency room visits. But in the event, it kind of just confirms that you are a patient and you're not just somebody who's utilizing the healthcare system with ER visits and hospitalizations for your sickle cell management. When you're looking for a provider, this could be a question that you ask. Do you have the ability to do outpatient infusions? And also something when you're looking at insurance, make sure that outpatient therapies like that are covered. But those are different strategies and ways to prevent the ERs and hospitalizations. But it's very frustrating. And I'll have patients once they're out of the hospital to come and see the nurses, because you have to realize when you're in pain, you are seeing the worst out of that patient. And so many of my patients are so bright and lovely that when they're in the hospital, I'm just thinking like, oh my God, I can't even imagine what they're thinking. And it's like so far off from what they're like from the day to day that providers really need to realize this is a patient's worst and we need to help them and lift them up and not judge them. Because as you mentioned, sometimes when you know too much and you're doing everything you were told to self-advocate for yourself, then you're being clumped in together as being a difficult patient or a drug seeker because they can't take anything but Dilaudid. They must be a drug seeker. When in reality, when you look at people who are prescribed narcotics as a whole, the percentage of patients who actually develop addiction or a substance use disorder is around 10%. Yet when you look at the care of patients and what sickle cell patients and those with chronic pain, aside from sickle cell are receiving, you would think that percentage is like 50, 60% because the judgment and the fear of just providing adequate medication it's heavy. Genotypes. So we know hemoglobin SS is the most common one. That's the one that's characterized by the rapid hemolysis or red cell breakdown. So we see a lot of pain and anemia. You have hemoglobin SC, which doesn't necessarily have as much red cell breakdown, but sickle cell retinopathy, for example, is more of a problem. But then we also see the genotype sickle beta thalassemia. And this is one that isn't really screened. So in the United States, we have the mandatory newborn screen that picks up everyone with sickle cell trait and sickle cell disease. But if you have thalassemia, say you have beta thalassemia trait, which means you have just one copy of that, that is not going to get picked up on a sickle cell screen. So say you have somebody with sickle cell trait and somebody with beta thalassemia trait, they have the potential of having a child with sickle beta thalassemia, and it might have never been on your radar because maybe that person didn't know they have trait, or maybe they didn't even know that that could have been mixed together. So there's a lot of education that needs to be ongoing. And I think this is where patients can be their best advocates and just know what your carrier status is. Because I think with this newborn screening, the point of it is for early identification of those with disease, but sickle cell trait is often brushed, oh, it's benign, you're going to be fine with it. And we don't focus necessarily on what it means for family planning. So by the time you're an adult, you might, unless you have a parent or you're really involved in your health, you might never have known that you had sickle cell trait. And then it's not until you're pregnant and finding out during that sickle cell screen that you have trait that what the probability of having a child is. And then you're in a predicament because you're already pregnant that you either are going to accept it and educate yourself and learn how to, what that exactly means. But there's a lot more than we can do. Connecting to people worldwide. I never imagined being able to have an impact on every single continent, almost, maybe not Antarctica, but so many different continents in this world that it's just been very rewarding. And just speaking to you today and just hearing the global impact, which I never fully appreciated until you highlighted that, has just been extremely meaningful. And it just pushes me to want to continue doing what I'm doing. And I think there's so many other advocates out there, including yourself, spreading awareness that we need to just continue doing it. Don't give up hope. Again, we're going to have low days and down days, but there is going to be change. It's just going to be an uphill battle. But if we stay together and keep that passion going, we will see that change.